avoiding reherniation, avoiding some of the long-term consequences of pain and other consequences of discectomy. And he's also going to talk a bit about a novel anchored closure device that's got some pretty strong evidence to suggest that this might actually avoid some of the long-term consequences of disc herniation. So we've got almost 20 participants right now, and I think it's going to continue to grow over the upcoming minutes, Professor Thomé. But with that, I'm going to ask you to start. And I also just want to make sure, one of the reasons we're doing this with a relatively small group is anybody who'd like to ask a question, you're going to be muted during Professor Thomé's presentation. You can either unmute yourself and ask a question, or go ahead and use the chat box at the bottom. And we'll try and really make this as interactive as possible to create a really useful educational event. So with that, Professor Thomé, thank you for joining us this morning in our teaching conference, and I'll let you start.
All righty. Good morning, everybody. Thanks so much for having me. It's a pleasure, particularly with UCSF. I know some of the people over there, so it's great to tell you something about the work we did. And I'm going to focus on some of the stuff on disc herniation that we have worked on. Let's see whether this is moving on. So I'm just going to start out with talking a bit about the state of the art of lumbar disc management. I think most of it you will know. Then I'll talk briefly about the concept of bone-anchored annular closure, and then about our results that we did get from the RCT on the Barricaid device. You may want to notice that I do have some disclosures. We were supported by Intrinsic for the RCT, and I do work as an educational consultant for the company, giving courses on the technique. So this may be a bias that you should be aware of. I would like to start out with talking, obviously, not only about Barricaid and annular closure, but also about lumbar herniated disc treatment. Again, probably one of the simplest operations we do as spine surgeons. And still, there are some tricks and important messages about it that I would like to give you. And I would also like to show you some of the results of the studies we did in the past. Please, all the participants, feel free to just interrupt or discuss, because I know how tough it is, particularly in the coronavirus time. I'm listening to webinars, it feels like 8 hours each day. So you get really tired after probably 15 minutes into each of those. So please feel free to ask questions and interrupt me anytime. So I tried to focus on treatment options. I'm not going to talk too much about conservative therapy. Maybe the only thing I would like to mention is that epidural steroids, if you look at the SPORT trial, has shown some efficacy, but we all know that this is probably only for a certain proportion of patients that will actually benefit long-term from epidural injections. But this is something we should consider before going on with surgery. But I would like to focus on surgery. I don't know what the state is right now in the US. There's some places in Europe where a lot of intradiscal therapies are still done with quite interesting advertisements, see what you've been missing, a new technology. We've always been very reluctant on any of those, and I'll tell you why a little later on in the talk. And then what I'd like to focus obviously mainly on is surgery and the different aspects of it. Disc surgery, as I said, is something that we do all the time. And the question is when to go for surgery in each patient, and then how. So it's about indications and the different treatment options and technologies we have available. The indications, I would consider the left side, the non-controversial ones, which is obviously cauda-equina syndrome, severe motor deficit, and very intense pain. The latter being rare, but still happens, that some patients can hardly be controlled because their pain is so severe even without a motor deficit. And then the so-called controversial indications for surgery, where a lot of people now tell us we should do all of them conservatively, which is the radicular pain, conservative to refractory to conservative care, and the low-grade paresis, grade 4 particularly. And I'm going to discuss those quite extensively because this is something that we have worked on in the recent months and years. Also, something that is very important to us, it may be different in the States with your different system, But since we have a socialized system pretty much here at the government and university hospitals, we do have an issue in getting patients to the OR at night, particularly if they have only a disc herniation and anesthesiology is busy with other stuff. So this is something where we have to discuss, is this a patient that we operate at 8 p.m. or we even start at midnight, or we have to do him the next day? But again, this may be different in your place at UCSF, but this is something I would also like to mention quite a bit. So starting with the most obvious indication, cardiac equina syndrome, there are some studies that have shown different time points that would be ideal for surgery. And most of the studies actually come down to that a cardiac equina syndrome with a massive lumbar disc herniation should be operated within 48 hours. And then you tend to have a decent result. So just hold on for a second. Sorry about that. And we know from a variety of studies that if you treat them later than 48 hours, only about half of the patients will recover, which is obviously dramatic if you have a young patient with urinary incontinence or sexual dysfunction whatsoever. Motor deficit, it's not that clear. If you look at the studies out there on lumbar disc herniations, some of them quite old actually, there are 3 prospective trials that did not find a clear benefit of early surgery. And if you look at this study on the left that actually focused on muscle strength recovery after microdiscectomy, they actually concluded that the severity of the paresis was the only predictor, and it was not the timing of surgery. The problem is, if you look at this, the duration of the paresis was actually a month on average. So we are far away from any type of early surgery. And on the right, you see great work from Wilco Peul's group from Leiden de Hague in the Netherlands. When they did their randomized trial on sciatica, they actually had a proportion of patients with grade 3 and grade 4, mainly foot drops. And they also found no difference in those patients when they were randomized to early surgery or conservative care. So they also concluded motor deficit does recover the same, which is not what we saw in clinical practice. So that's why we did this first Innsbruck study, and this was published some time ago, where we actually looked at 330 patients that were treated as an emergency, or let's say they were acutely admitted with a deficit due to a radicular compression syndrome. And they were treated by surgery, and they were followed up in this first series for at least 3 months. And we dichotomized the patient cohort in patients that were treated within 48 hours of onset of paresis and after 48 hours of onset of paresis. But you see below that even the patients that were treated late were treated on average 8 days after onset of paresis, so already quite early. And the results you see here, this is the outcome after 3 months. On the left side, the 3 bars show mild, moderate, and severe deficit treated in the early group. And the right 3 bars show you the corresponding deficit severity and those patients treated after 48 hours. And as you can see, there's obviously a highly significant difference. And if you look at the numbers, if you treat patients within 48 hours, they basically all recover, even if they have a complete foot drop, paresis grade 0 out of 5. If the patient has a severe deficit for more than 48 hours, probably 1/4 doesn't improve at all, and about 2/3 actually recover quite well. So we published this and presented this at some meetings, and then the argument was, well, again, oh sorry, I forgot about this. There's if you looked at the most important factors predicting outcome or predicting motor recovery, it was the duration of the deficit and not the preoperative grade. Very different to the studies you saw earlier. And so the argument was, well, those patients that do recover within 3 months, that doesn't really count, because those patients that were treated later, they just take longer to recover. So at the end, they will be the same after 1 year. So we now followed up those patients. This is under review at the moment, for at least 3 years, on average 5 years. So obviously after 5 years, you will have no recovery anymore of motor deficit. And one of my residents did a great job in actually seeing all those patients back again, except for 3 that died. So follow-up was tremendous. And now we looked at 3 groups, treated within 48 hours, treated within 2 to 7 days, and those treated after 1 week. And if you look at the results, again, the graphs are a little different than in the first publication, but you see the outcome at 5 years. The left bars are those treated within 48 hours, the middle within 2 to 7 days, and the right after 7 days. And the severity of the deficit, as you can see, those patients with severe deficit, they recovered basically all to almost normal if treated within 48 hours. If treated between 2 to 7 days, some recovered, some did not. If treated after 7 days, nobody recovered. And if you look at this full recovery percentage, obviously huge difference depending on timing, and no recovery, same thing, huge difference. If you looked at mild deficits, you see a little different story. The patient with a mild deficit, which is only a grade 4 out of 5, they also recover if you treat them within 7 days. Only if you treat them after 7 days, a certain percentage, about 1/4, a little bit more than 1/4, does not recover completely and don't show much recovery. So the next argument that we were faced with was that this is a retrospective study, obviously biased or potentially biased. So we looked at a smaller cohort of lumbar disc herniation patients that were treated at our department. And this was prospectively collected data. 120 patients operated within 3 months in 2015. And half of them, by chance, half of them had a motor deficit. And 6 patients actually had a caudate equina syndrome. Interestingly, out of those, 4 were operated within the first day and had a full recovery. And there were 2 patients that actually reached us, I think, on day 4 and day 7, if I remember correctly. Those did not recover at all. And then we also analyzed the patients according to their timing of surgery, before or more or less than 72 hours. And here on the left, you see the outcome for the moderate severe deficit, on the right for the mild deficit. And it exactly shows the same results that we found in the retrospective study. If treated within 72 or 48 hours, even with a severe deficit, the patients almost all recover. Very different if treated later. And if you have a mild deficit, you get a better outcome even with later treatment, but still a clearly significant difference between the 2 groups. So this has actually led us to change our policy. And whereas we always had discussions with anesthesia before, now it's quite clear a patient with a severe deficit is treated as an emergency, whereas this may be different with the patients with a mild deficit. So our conclusion was that if a patient comes in with a radicular deficit, severe or moderate, they should be treated within 48 hours of onset if they reach us. Many of them don't reach us, obviously, within that time period. And if they have a mild deficit, even a grade 4 out of 5, if it's a disabling paresis. I'm not talking about a mild foot drop, but if somebody has a quad paresis and can't walk the stairs or something like that, and is a young, active, maybe even running individual, we would definitely also in a grade 4 paresis go for surgery within a week to avoid later problems in this patient population.
Professor Thomé, let's pause there. That's some really important research you're sharing with us, and I was aware of part of that, but that's terrific what you shared with us in addition to what you've already published. I wonder, in terms of mild versus severe, so often in terms of a clinical presentation, somebody with acute radiculopathy, it's awfully hard to get a good exam of the anterior tib or the EHL because they're so limited by pain. So my understanding is that a severe deficit is 3 out of 5 or less. Is that right?
Well, we said a moderate was 3 out of 5, and 2 or less would be a severe deficit.
Okay.
And I agree with you. This is one of the limitations. What we try to do is actually, when the patients come to our emergency room, they actually receive pain medication pretty much right away automatically if they are in severe pain. And quite often, by the time the neurosurgeon sees them, which is maybe a half an hour later, quite often, to be honest, their pain is somewhat better. And so we believe the assessment of the motor grade is reliable. But I agree with you, there may be some patients that we misjudge, particularly if you talk about grade 4 out of 5 in relation to normal function.
Terrific. Well, this is important information. It's always a great controversy of what to do with the motor deficit in the acute setting. So thanks for sharing that data. And I want to encourage again any of the residents fellows on the line, either unmute yourself or enter the chat box. But we're wondering if this is interactive as much as possible. Thank you.
I have a quick question while we're on the subject. Were there any exceptions made trying to get patients in sooner if they had, more, multiple motor groups that were, severe deficits or sudden loss of, bowel and bladder, or if there were lesions that were higher up, like right at L1, more concerning lesions?
Yeah. No, we looked at those patients more with metastatic spinal disease, but the series I'm covering here did not have any patients that involved the conus or the spinal cord. So there was, I think, one patient at L1-2, but there was no conus there in this particular patient. So we only have patients with, if you will, nerve root compression and not true conus compression or spinal cord compression.
Okay, thank you.
Alrighty, then I'll move on. So obviously indications for surgery, as I said, controversial. If you look at the sports trial, it's quite clear that surgery has a benefit, even though there was a very high crossover rate. I'm sure you know all this data better than I do. But overall, there was an indication for surgery in those patients, even if they had only pain, which is the majority of patients. And then there's the work from Wilco Pearl from the Netherlands, who randomized patients to early surgery versus conservative treatment. And what we know now is that basically a number of patients that were initially treated conservatively cross over to surgery, so they actually end up needing surgery. Luckily enough, they had the same success rates in Pearl's study. So if you treated them a little later, at least you didn't do any harm to them. But if you look at all the 5 RCTs that have been published, there is superior outcome with surgery, particularly in the short term. Patients have rapid pain relief. But after about 2 years, the curves come to pretty much the same end, and even the patient with conservative care recover. But obviously, as we all know, if you are out of work for several months or even half a year, this will have a dramatic impact on your life. So early surgery is quite indicated in those patients. And we also know, again, from the sports trial and some other studies, that if you do surgery later than 6 months after symptom onset, you will have poorer outcome. Whether this is psychological, loss of jobs or whatever, it's unclear, but it's quite obvious that this is the case. So that we now, at least in Europe, summarize that surgery should not be done within 6 weeks. We always try to go for conservative care for 6 weeks, and it should be done within 6 months. Again, this is just on a different page probably, but it depends on the country where you're in, and it depends on the insurance you have, even in a socialized system than ours, where there are good data on if you're privately insured, you will get disc surgery earlier than if not, even in our system. And if you have a lot of spine surgeons in the same place, you will also get the surgery earlier, because obviously there will be more people that actually do it. So there are some other influential factors, but this should be the main rule that most of us, I think, go by. It's cost effective to do surgery, so I don't want to go too much into this, and come to the second larger part of my talk, talking about the surgical techniques. If you look at the history of disc surgery.
If I can interrupt one more time.
Sure.
Really terrific information. I love the overview and the background that you gave and the evidence for early surgery. A couple of our audience here, a couple of our participants are actually part of our non-operative group, and we've got a mixture of neurosurgeons and orthopedic surgeons. And I just wonder what you're talking about there in terms of variability in care is such an important issue in the States, certainly, and worldwide. The observation to some extent of what you get depends upon who you see. And whether you see a neurosurgeon or orthopedic surgeon, or whether you see a non-operative physiatrist compared to a physiatrist. And I wonder if I could just start with a question of how does it work in a national or in your government healthcare system where your hospital is? How does it work in terms of triage? When do people get triaged to the physiatrist or to the pain specialist versus to the surgeon?
That is a very difficult question. The regional variability is huge. In our place, it's actually quite simple, mainly because we live in the state of Tyrol. It's in the mountains. We have a population of 1 million people, and some areas of northern Italy and some other states we cover. And the problem for us is actually that we see a lot of patients that are sent directly from the GP to us. It's a quite direct referral. And so we see patients quite early. And but because of being in a government system, we have a waiting list for disc surgery of probably 8 weeks, and sometimes even up to 3 months, which was the worst we had like 5-6 years ago. Now we changed something, so most patients will have to wait 4 to 6 weeks for disc surgery. And the interesting thing is, I used to hate waiting lists. Now I think it's fantastic, because probably 1/3 of the patients don't need surgery. And the Tyrolians are very straightforward people. So they end up coming into your office and saying, oh, I'm scheduled for surgery. And then you ask them, well, how are you doing? Oh, doc, I'm fine. Well, what about the pain? No, I don't have no pain anymore, but I was scheduled for surgery. So they still show up. But it's quite interesting that you should give those patients those so many, I would say 6 to 12 weeks. But in some areas, particularly in Germany, where there's more competition in the healthcare system, people in the big cities, they get surgery within 2 weeks, because there's so many surgeons out there craving for patients.
Interesting.
Okay,
That's great.
Going back to,
real quick,
yeah.
Has anyone ever compared outcomes? Because I know in Germany, for instance, everyone's publicly insured, but you can also have private insurance. Has anyone ever compared outcomes looking at the privately insured patients, and if they have access to better care, do they report superior outcomes?
No, there's no data like that, which I think is mainly for political reasons. Nobody wants to look into that, because there's always the question about the two-class medicine. And also in Austria, you can be privately insured, even though everybody has health insurance. You can get add-on private insurance. The only thing we know is that if you are privately insured, you have a significantly higher risk to get surgery. But we don't have data on whether your outcome is better or potentially even worse because you're treated too early. Nobody knows. This has not been looked at, and it would be politically probably a bomb that you may actually have explode there.
Yeah, that's interesting.
I'll just add to this briefly. It's such an important topic in universal coverage countries, and so I actually looked at this in the National Health Service. I wrote a paper about patients who were covered by the NHS versus Bupa, which is a private healthcare system in England. And it turned out that, and this was for hip replacement. So it turned out that patients undergoing a hip replacement came to surgery with less disability and significantly younger in the private healthcare system than in the public healthcare system. And when we looked at outcomes, the outcome was slightly better in the patients who were treated privately, in part because they started off with less severe disability and less contractures. The satisfaction of patients was actually very similar between the two groups. But looking at range of motion and some objective measures of outcome was slightly better with early treatment. But the question then becomes is what's the appropriate place to intervene? Is looking at revisions down the road if you're operating on people who are too young. But there were some differences between the private and public system in England.
Very interesting data. And it's an interesting question. I think the only thing that we learned from this discussion is that even if you are working in the private sector and you should have your at least 6 weeks of conservative trial, you send them to a good physiatrist, et cetera, do some conservative care. I think that's very important. And actually, to be honest, being from Germany originally, when I'm called by my friends or family and they tell me, oh, I have a disc herniation, I'm scheduled for surgery next week, then I always tell them, then go to somebody else because she is not busy enough. You should have somebody that can take you on maybe in 3 or 4 weeks. But that's very subjective, obviously, I have to admit. Okay, so I'll move on with the talk. For particularly the residents, I'm always surprised that our young residents and sometimes even young faculty, they don't even know or remember how disc surgery was done in the old times, where people would actually use carettes and scrape out the whole disc in a normal disc case, what we would do now for an interbody fusion. So this is where we came from a long time ago. And then microdiscectomies were not introduced until the late 70s and probably became the gold standard. Then some less invasive procedures were performed. I'm going to quickly touch on endoscopic discectomy, and I'm happy to discuss this further if you want to, but I tried to not focus on it too much. Obviously, we want to improve the results overall, and there are different accesses to different locations of disc herniations. Like we use for extraforaminal approach discs, we only use tubular approaches extraforaminally. And for upward herniated disc, we usually use a translaminar approach. So this is our standard procedures. And if you talk about endoscopy, I just put up one rather old study because I think it's one of the best out there by a German group who are very, very proficient in both the endoscopic technique and the open technique or microscopic technique. And they actually found that the results were the same. There was no difference in outcome with whether you did it endoscopically or you did it openly microsurgically. So to summarize, there are short-term benefits for endoscopic disc surgery. I think that's quite clear. And if you are well trained, it's also safe. There's no doubt about this now. But there are 2 problems that we face for large departments. One is that the outcome is not better if you look at it in the long term. And unfortunately, many of the results that are published are by experts who do, 500 endoscopic cases, 1,000 endoscopic cases a year. And this is very difficult in a big spine department where you cover everything. It's very difficult to get to those numbers, particularly individually and even more so in training. And there is a learning curve. And I've seen quite a number of patients with neuropathic pain after transforaminal operations with endoscopic surgery. So there are some problems to it. And there's always a discussion. I apologize, this is a German slide, but I liked it so much. The slide shows the transition from open gallbladder removal to endoscopic or laparoscopic. This took internationally 3-4 years from basically everybody treated open to everybody treated laparoscopically, because it's so much better. And if you look at endoscopic disc surgery, it's out there for 30 years. Probably technology is very good for about the last 10 years, and it still has not caught on. So most likely it's not that much different. Let's face it. Even though it's a nice technology and we use it as well.
We've done a couple of teaching programs now on the endoscopic discectomy, but still waiting for one of our faculty. We've got 12 people doing full-time spine surgery between orthopedic surgery and neurosurgery at UCSF, and no one's really picked that up as their niche yet in our center, but we're still hoping that maybe somebody will become an expert at it.
Yeah, it's the same for us. We actually have I've now 4 people that are working on it, and we're still in the learning curve, obviously. And I think we'll keep on doing it for the future as well. But it's not that you would think it's so much better that some of the proponents say it's good technology, but it's difficult in big centers, I would say, that do everything. Tubular, there's this one study that actually showed that tubular was not as good as those microscopic speculum type retractors. To be honest, I don't really think that's the case. I don't think it makes much of a difference for a lumbar disc if you do it through a tube or do it through a mini open whatsoever procedure. I don't think there's a big difference there. Then something we did a long time ago, we did a study on sacrosteectomy I would quickly like to share with you, which we published more than 10 years ago, where we randomized patients to just fragmentectomy and microdiscectomy, not very aggressive, but the limited microdiscectomy. And what we found is that actually the patients in the sacrosteectomy group fared better. The patients in the discectomy group at late outcome, which was at 2 years, had more pain, particularly more low back pain. And if we looked at modic changes by MRI 2 years after surgery, we saw that the patients in the discectomy group did much worse, not necessarily clinically, but looking at their modic changes. So if you do go in the disc, it's probably not the best thing you can do to scrape out that disc in your regular disc surgery, something we were taught when we were brought up. And this brings us to this very difficult surgical dilemma that if you are very aggressive at doing your discectomy, you end up having a lot of low back pain in the years to come, but you may have very low recurrence rate or lower recurrence rates. But if you are very limited or very conservative with your discectomy, you preserve the disc, you have less low back pain in the future, but you have more reherniations. Now, to be honest, for a surgeon, it's actually better to have more low back pain and less reherniations, because then you'll be able to fuse the patient after a few years. So he'll come back to you and he'll still be happy because you can just say, well, that's the natural cause of the disease. It's not my fault. But if he comes back with a reherniation, most likely he'll tell you, well, why you didn't do the job right? Why did I reherniate? So this is something that's a surgical dilemma we face all the time. And this is something we also looked at. This is a study published a couple of years ago looking at how extensive surgeons take out the disc. And as you can see here, about 1/3 just do a fragmentectomy if possible. And quite a lot of another third do a limited discectomy, just taking the loose fragments. And about another third, maybe the more old-fashioned surgeons, you never know, they do a very aggressive extensive discectomy. So this is how surgeons treat discs at this point in time. And if you look at just what you do during disc surgery, one thing, you want to resect the disc herniation. That should cause relief of symptoms. And then we were taught to remove the nucleus to reduce the recurrence rate. But we also know if we remove the nucleus, we will have a higher loss of disc height. There's some studies out there. We have more low back pain over time, particularly if we look at time ranges of up to 10 years. So ideally, so you actually do get problems with removing the nucleus, which then can end up in the so-called post-discectomy syndrome. And this is obviously the negative part of disc surgery that you would not like to have. So we here, and I personally believe that if you can do a fragmentectomy only and just take the sequester out, this is probably the best. And that's also why I'm very much against interdiscal therapies like ozone or laser discoplasty, which in some European countries, they're not that uncommon. But I think you should not destroy the disc. And if you look at the systematic reviews, I'm not going to do this in detail now, they also show that it's not effective. Very simple. Those interdiscal therapies have not proven efficacy. But we still tend to be afraid of reherniation, and reherniation is a big problem for us. There are a number of factors related to reherniation.
Let's pause there again, because again, I've got a number of our participants from different backgrounds. I see Andrew Jack there from our neurosurgery fellows, so many orthopedic fellows who have operated with multiple different surgeons. I wonder if I might be able to invite some of the surgeons or fellows who have seen multiple different surgeons in our group do discectomies. What kind of variability have you all observed for our residents and fellows? Anybody want to comment on the variability you've seen with different surgeons? Just go ahead and unmute yourself if you want to speak up.
I've found with the surgeons that I've trained with and worked with that the fellowship trained or complex spine surgeons tend to be a little bit more conservative with respect to their discectomies and tend to perform more of what's being described as a sequestrectomy, whereas the ones that are not kind of selling themselves as a complex spine surgeon, but just doing routine spine work, tend to do more aggressive intradiscal discectomies.
That's interesting. You know, I wonder, Professor Thomé, if you could talk a little bit about, so do you put the pituitary in the disc at all, or do you do any irrigation in the disc at all to try and flush out any loose fragments when you're doing a sequestrectomy, or do you not really enter the intradiscal space at all?
Well, what I do is I don't enter it at all. The reason being that when we did the trial, that was 2000 or something like that, 2000 to 2002, this old trial on sequestrectomy. It was so hard for me not to put the pituitary in, because you were trained to put the pituitary rongeur in the disc and take it out. And in the study, obviously, we defined not to go in at all. And it was so hard for me that I really suffered the first few cases. But I learned that you don't have to. And now what I do is, if I don't have a big hole or don't have a true hole in the annulus, I don't go in. If I see a small slit, I don't even go in, and I don't even irrigate unless there is a clear hole in there. And then I'm at actually, but the problem is, once you put your pituitary in, you always have a so-called big hole, because then it's going to be at least 3 by 5 by 5 millimeters. And then you're going to end up with the big holes I'm going to talk about in a minute. So if I take the fragment and I don't see a big hole, I stop.
Okay, that's what I wanted to get at too, is as you're aware, I can get to this, but Carnegie showed pretty clearly that the size of the original annulotomy has a lot to do with the risk of recurrent disc herniation. And you're going to get to that data soon. And so if somebody's got a large annular defect already, then maybe in those instances, you might go into the disc, or even then you don't now.
But if I have a big hole, then either the patient would qualify for an annular closure device, ideally. And if not, I would, or if I don't think he would be a candidate for whatever reason, I would do a limited discectomy. Then I would use irrigation. Then I would take the rongeur and try to take loose fragments out. But then still, I know this patient will have a higher reherniation rate than the one where I didn't find a true annular defect.
Okay. You know, you're going to get me in trouble because I'm doing a discectomy later this morning. We're on limited OR time right now, but I'm not sure which of the fellows or residents might be working with me, but you know that you're going to be quoted later on this morning, and I'm going to be restricted in how much I'm allowed to go into this now.
All righty, then I'll quickly move on. So risk factors for reoperation, we know that reherniations happen in about 8% on average in our disc population, 5 to 15% in most studies. And this is particularly for those that have a high disc, for those that have a still mobile disc, and most importantly, that have a large annular defect. We also know, this is just as a side aspect, that if you do an MRI on your patients, even if they're asymptomatic, many of them will actually have some kind of reherniation on MRI. So you will actually have about 1/3 of your patients. This is, again, a nice study done out of the Netherlands that actually showed that you do have reherniations if you do an MRI. So I don't try to get my patients to do an MRI after surgery. Then now to the last part of my talk. We all think that disc surgery is one of the best surgeries we do. If you talk to your patients, you tell I'm sorry that this, I think I dropped out. I'm trying to go back in. Sorry about that. I think my connection was lost. Do you hear me again?
Yeah,
we can hear you.
Yes, sir.
Sorry about that. This is just a study showing the long-term results, and we know that patients that need a second operation, they do much worse. If you have a success rate of 80% in primary discectomies, this comes down to less than 60% in the recurrent patient population. And this is true for all the factors. The graph on the right is from the big Barricaid trial I'm going to show you in a minute. And we also could clearly show patients reoperated for whatever reason do much worse. So one of the major reasons for dissatisfaction is reoperation. And again, just as a reminder, the dilemma between aggressive and limited discectomy. And this led us to introduce the concept of bone-anchored annular closure. So overall, we have a 20% cumulative risk of further surgery within 10 years. And we would ideally, even patients asked us 10 years ago, well, why don't you plug the hole? If we told them that the hole can cause reherniation. And the problem is that we know from this orthopedic surgeon that you see there, who actually put a pressure probe into his disc, which I wouldn't do personally myself, but he did. And he did all kinds of exercises. And we know from him basically that the pressures in our discs are extremely high. They are more than 10 times of what our car tires have. And so these extreme loads make suturing or glues impossible. It's not going to work. And we also know from very old American studies that the annulus is not healing well. Healing is very, very poor. And this is why if you put something in the disc, which has been done in Europe for a variety of reasons, nucleus replacement, etc., they all come out. They all don't stay in because the pressure is just too high. And the same is true for annular closure devices. Now, as you pointed out already, from Carragher's landmark study, we know that if you have a large annular defect, he had reherniation rates of up to 30%. And nobody believed that. Everybody said, well, I never have a 30% reherniation rate. He's doing something wrong. But he actually showed that this was the case for his patient. And this was in a subset of patients that had a high disc, more than 5 millimeters, and a wide defect, more than 6 millimeters. And these patients had a very high risk. And now, Intrinsic, they developed this device, which is supposed to plug the hole, prevent reherniations, and by thus ideally preserve disc height. And what was very important is that they have a bone anchor that secures the device to the bone. And I got involved with the company more than 10 years ago. I never did anything before with annular closure because I felt that they're all going to come out after our European experience with nucleus replacement. But if you anchor to the bone, that does make sense. And you may have to look at this. This is the device. It shows the titanium anchor and it shows the flap that's supposed to plug the hole. And you see the two X-rays showing how it's implanted. And this is the device we did the large study in Europe on. So this is the indication. I'm just going to put this in because it's an FDA approved device now. So you have to, obviously, if you give a talk on this, you have to put all the devices in there. I encourage you to read this later on. But the important thing, it's used for large annular defects. It comes preloaded and is implanted using X-ray at surgery. So what you're supposed to do is actually you do either a sequestectomy only, and then you see a hole. If you have no annular hole, obviously you can't use the device because you don't need to plug anything. But if you have a hole, or if you need to do for whatever reason, because it's a protrusion or whatever, you end up doing a limited discectomy. You have an opening of the annulus that's big enough. You measure the defect to be sure that it's a large enough defect to actually get the device in. Then you align the trial. You have to be in line with your incision with the disc space, and then you implant the disc space under fluoro control. And this can also be done through tubes, but obviously also through open approaches. And it's MR compatible. It doesn't cause much of an artifact, as you can see on the right side here, in a patient who still has a disc protrusion after surgery and some narrow canal, but you can still see that there's enough space for the lumbar nerve roots. And if you have to redo cases, which rarely happens, actually the bone grows over this anchor very quickly because it's a very small bony cut, if you will, and you can nicely see that this grows in very to a very stable situation. And what I was involved is, as I said, I've been involved with the company for quite some time, and I'm to be honest, I'm a bit proud that when we first talked about how to look at this device, that we actually they took my advice to really go step by step, go with preclinical work first, then do prospective small or monocentric studies, and then go for a large trial. And they actually did this. So there were a couple of prospective trials early on I'm not going to talk about. And then the main trial was this superiority RCT to evaluate the inner closure device in discectomy patients. Very importantly, it's a superiority trial, different to most IDE trials we normally see. Like if you have a disc arthroplasty trial, that is usually a trial that's a non-inferiority trial, trying to show that the artificial disc is as good as ACDF. And this is statistically easier than showing superiority. This was a superiority trial trying to show that this device is superior to gold standard, and gold standard would obviously be no implant. And we did this in 21 sites in Central Europe, 554 patients enrolled, one-to-one randomization. What is also very important is that the patients were randomized after the discectomy is complete. So the surgeon did not know at the time of discectomy whether the patient would receive an implant or not, to rule out bias that you would treat the patients differently depending on whether they get the device or not. 1.3 cc's of nucleus was removed, which is pretty much normal for a limited discectomy. And very important, they had to have a high disc, more than 5 millimeters, and a large defect, at least 4 by 6 millimeters. So this is not your everyday patient. This is a high-risk subpopulation of patients, maybe 20, maybe 30%, maybe even more, depending on where you work at. Inclusion, exclusion criteria, as I said, the most important, I'm not going to cover the rest, is the disc height and the size of the annulus. They obviously had significant pain, etc., etc. And like with most studies that are also aimed at the US market with for an FDA approval, we looked at 2 endpoints, reherniation and a so-called safety and effectiveness composite score, just in an attempt to try to see an overall success rate, like you see with the IDE trials that you all know and are well familiar with. I'm not going to touch upon details, but you're happy to ask me anytime. What's also very important is that we were allowed to do low-dose CTs and MRIs at annual intervals. So we actually know exactly how those patients progressed, how the natural course of the disease was. And what is very important, we actually learned a lot in the control group, maybe even more in the control group than we did in the device group on how those patients behave. I'm able to show you 3-year data with a very good follow-up rate of 90%. Typical patients, average age 44 years, significant leg pain, a little less back pain, significant ODI, mostly L4, 5, and 5 is 1, as we would expect. Rather large defects, as also we would expect. Nucleus removed the same in Barricaid and control, which is very important because you want to make sure that those patient groups are not treated differently. But since they were randomized afterwards, they were not treated differently. Operative time longer in the device group. And this is now the main result. After 3 years, they had a reherniation rate in the control group of 30%, something none of us would believe. And actually, we looked at our own data from our center, and a female patient younger than 40 with a high disc had almost a 50% reherniation rate. Dramatic in those patients. This is a small group, I admit, but females, young females, high disc, had tremendous reherniation rates. And in the control group,
symptomatic, the 50% who reherniated in a young female, how many were symptomatic?
Well, actually, about almost 40%, 36%.
Wow.
And which was very high. And because we all thought, well, I'm not going to have a 30% reherniation rate, but we did have the same results that Carnegie found, interestingly enough. And the Barricaid ended up with lowering that rate to about half. We can discuss about this in a minute. And reoperations were also cut in half because not every herniated patient is reoperated. The device, the number is a little higher of reoperations because 2% of patients had a device complication that needed removal of the mesh or whatever. And that's why the two curves come a little closer together if you look at the reoperation rates in comparison to reherniation rates. But again, highly significant, obviously. And here you see on the right side, the reherniation in the control group, in the Carnegie study, and in the Barricaid group. And you can see how perfectly this imitates the Carnegie study, which we all didn't really believe it was true. And also what was very important to us, if you needed to reoperate patients, if they needed a fusion, you could do any type of surgery, even with the device. It didn't cause any problems, even though the fusion rate was significantly lower in the device group than it was in the control group, because control group had more reherniations and they ended up with more fusions later on down the line. There was something very interesting that we found a lot of endplate changes, both in the control group. About half the control patients showed endplate changes after limited discectomy, and almost all of the Barricaid patients showed that. So this was a big concern we had, that this would cause some problems, because as a spine surgeon, if you hear endplate changes, you're always worried about low back pain and modic changes and degeneration, etc., etc. So we looked at this in extensive detail. We did not find any clinical effect. Actually, funny enough, those patients that had endplate changes in the device group had less pain, not statistically significant, but a trend to less problems. Maybe this is an adjustment of the system of the body. We don't really know. And we also looked at this in detail and looked how those endplate changes developed, because at first we were worried if you get an endplate change after 6 months and this keeps on growing, you have a destructed vertebral body or endplate after 5 years. And it turns out that this is a phenomenon that is self-limiting, and they don't keep on growing. And we did a number of publications on this I cannot cover, but I'm happy to answer some questions. If we look at further degeneration, there was no difference in the ongoing degeneration of the discs within 3 years. There was a trend to less degeneration in the Barricaid group at 3 years. If you look at the Kellgren-Lawrence classification, this degeneration scale, but this was just barely not significant. So obviously, hopefully for the future, but we don't know whether that's true, we can also see that maybe there's less degeneration with the device. Something that is very important, and I would like to put to the end before I finish, the number of Barricaid patients outside of the trial has been quite large as well. And interesting enough, in some expert groups that I know well, and I actually have to admit I believe them and I believe their data, particularly Adisa Kusumovic with 171 patients in the middle. Reherniation rate in expert groups outside of the trial had significantly better results, which we don't really know why. Because to be honest, a reherniation rate of 14% is still quite high, even though this is a high-risk population. And one of the reasons may be, again, not evidence-based, that we've learned that if you use a wider mesh, you tend to plug the hole better. And the patients that have reherniations, they tend to herniate next to the device because the annulus is probably too insufficient in width. And so this may be something that actually is a way to even improve results with the device. And many of the centers that use the device commercially are now doing some kind of oversizing. This is my last slide. You're very welcome to look through the literature. I had the honor to be the chair of the publication committee for the Barricaid trial. And we are at 44 peer-reviewed publications now on all the details on the Endplate changes, on complications, on whatever. So feel free, obviously, to look through those and look at all the data in much detail. And I would like to, this is another indication and warning slide. I think that has to be put in. So look at this if you have time. And I would like to thank you for your attention. It has been great. And I hope you have some more questions for the last few minutes. Oh, last 2 minutes. I apologize for being a bit long.
Claudius, thank you so much. That was absolutely terrific. And I appreciate the effort that you made to really go through some of the basics on the surgical technique, your excellent work on the timing of surgery, and then finally, congratulations on your work with the Barricaid device. Maybe I'll start with a question. I hope some others will have some questions as well. But in a nationalized healthcare system, such as where you work, when you bring in a new technology that adds a cost, what is the process to introduce new technologies, be it a disc replacement or an annular closure device? What's the process to get that approved in a nationalized healthcare system?
It's actually, it's changing at the moment. Up until now, you had to provide some evidence for its efficacy, usually in a large randomized trial. And if you did that, you had a good chance of getting it approved. And then you would try it out at a number of centers. They would calculate the costs, and then you would get a code that covers a certain amount of cost that the government-based system considers adequate for this treatment. And if you don't have adequate proof for its efficacy, you will not get it reimbursed.
And is the device now approved in all of the German public hospitals or Austrian public hospitals?
Well, that's a very difficult question. It was approved already for some years, actually. And they were in the process of finding the right costs for it. And then there was some issue with the changes in the regulations and some new manufacturing details. I don't even know all the details about it. You can ask the company; they know it better than I do. And that's why they had to reapply. So they are now, even though it has been approved, they now have to reapply, which seems a little ridiculous. That now getting FDA approval, which has been much harder than getting approval in Europe. So now it's approved in the US, and we cannot use it at this time now because they're in the process of reapplication, which most likely obviously will run well, but this is the current situation.
We've certainly collected a lot of data to support it. I want to encourage others to unmute and ask any questions. Maybe I'll just ask another one briefly. So my understanding is that an annular defect of more than 5 millimeters in height or 6 millimeters in width. Is that the strict indication now?
The strict indication is higher than 4 and wider than 6. To be honest, we use the paddles to measure the defect, and the height is very important because you may not get the device in. And also if the size is not, but to be honest, most defects in any disc that's that's higher than 5 millimeters is, if you went in with a pituitary rongeur, it's bigger than 4/6. Basically all of them. Even though people try to do a slit cut and not a box cut or whatever, it ends up being more than 4/6. Not necessarily if you look at it, but if you use the paddle to actually see where it's weakened, where the annulus is weakened, it's almost always that size or more.
Yeah, so sometimes when you look at the architecture of the posterior annulus as well as the posterior longitudinal ligament, they're a bit supplemental there, and so really seeing the width of the annulus is important to distinguish, I'd imagine, between the PLL and the annulus. Is that true?
That is true. That is true.
Hi, Dr. Thomé. I really appreciated the talk. Very, very impressive work. I had a couple of questions. I would assume that the risk of, or the incidence of reherniation is going to be higher at 5.1 or 4.5, for example. But the first question would be, did you see a difference in the incidence of reherniation between levels in the lumbar spine? And then secondly, this is something that Dr. Berven had brought up earlier on in the year, actually. Did you see a difference in the risk of reherniation between the different types of annulotomies that were done, whether it be cruciate or box type or what have you?
To the first question, no, there was no big difference in reherniation, a little but not significant between the different levels. That was pretty much the same. We actually looked at the type of annulotomy, but found no difference. Again, we are not sure whether the documentation was proper in all cases. And most likely, as I said, it does not make that much of a difference how you incise it, because at the end, if you go through your annulus with your pituitary, you're gonna have the same size hole, no matter whether you incised this, it was just a slit or a cruciate. The worst, I would guess, but we can't prove it even in our trial, is a box-shaped defect may be the worst. But again, putting the pituitary in causes your 5 millimeter defect always.
Yeah, hi, this is Oscar. If I can just maybe add to that just a little bit. We did publish one paper looking specifically at the control group. So this is going to be the discectomy only group with these defects that are at least 6 millimeters wider. So there, that manuscript actually goes through, they perform logistic regressions and all the different factors. So both level and the defect geometry, as well as the herniation type, were all different variables that were checked. And as Professor Thomé stated, none were found to be statistically significant. But that article would, I think, have a lot of different things that you might find interesting.
Well, Professor, thank you again for absolutely terrific lecture. Lots of great information. Thank you for supplying some of those references, and I'll share it with your permission. The longer PDF of your presentation with the residents and fellows, if that's all right.
That's all right. I'll send you the latest version because I made some final changes, if that's okay with you, so you can actually distribute the one I actually finally did talk about.
Terrific. Well, thank you again for contributing to our teaching program, and I hope you remain well. What's the status of COVID in Innsbruck now?
Well, actually, our neurosurgical ICU is COVID ICU, but we are doing very well. We have very limited numbers and we haven't had any new infections within the last several days. So we seem to be over at least the first wave. We are opening up again. We are doing elective cases again. We started last week. We are not up to full speed yet. We're up to about 70%, but we are doing quite well, to be honest. We are pretty happy.
Well, terrific. Stay well in Innsbruck, and thanks again for your contribution.
Thanks for having me. It's been a pleasure.
Bye-bye.
Thank you.
Thank you all.